Hi, I'm Pat Anderson, editor of MIMS Learning, and I wanted to tell you a little bit about the MIMS Learning subscription. This annual subscription gives you full access to exclusive subscriber content, ranging from clinical reviews to extended learning and recordings of our webinars. So come and check it out. If you take out a subscription, you'll find that it gives you stimulating learning, keeps you up to date on all the hot topics, and helps you with your appraisal process. So have a look today at the MIMS Learning subscription. You'll find it'll really add value to your learning.
Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Rhiannon Ashman, Deputy Editor of MIMS Learning, and I'm delighted to be joined today by my colleague Dawn Liz Powell.
Hi.
Hi Dawn. We've been seeing a lot of each other recently, haven't we? This is the second studio episode in a row that we've done together.
I know, because our colleagues keep going on holiday.
How dare they? But in this episode, Dawn and I are going to be talking about a topic that can be challenging for both patients and clinicians, and that's sexual problems. We've heard from several GPs that consultations for sexual problems are on the rise in general practice, so this podcast episode will hopefully help you to feel better equipped to manage these consultations confidently and sensitively. So sexual function is an important part of healthcare. Sexual problems are common. The National Survey of Sexual Attitudes and Lifestyles found that 51% of women and 42% of men reported having experienced sexual difficulties in the past year. But despite the increasing consultations that our GP advisors have told us about, there's a big gap between prevalence and presentation, isn't there?
Yeah, so according to that survey, 1 in 6 people say that they have had a health condition that has affected their sex life in the past year. Fewer than 1 in 4 men surveyed had talked about this with a healthcare professional, and for women this figure was 1 in 5.
That really highlights the hidden nature of the problem, doesn't it?
Yeah, and a study from Finland that was published this month, August, confirmed this. This showed that although sexual problems are common, they are rarely inquired about or treated in appointments with GPs. The researchers highlighted that patients may find it incredibly difficult to bring up such concerns on their own because sexual function is such a deeply personal matter. And I would add that if a person is a member of the LGBTQIA community, they may fear judgment or have had bad experiences in the past. Therefore, if a GP doesn't broach the subject, sexual dysfunction can remain undiscussed.
Yeah, and the impact of that can be significant. Untreated sexual problems increase the consumption of health services. More on this a bit later. And of course, they have personal costs. And that Finnish study that you mentioned, Dawn, surveyed 402 GPs and found that while a vast majority, over 92%, considered treating sexual problems an important healthcare issue, they faced real challenges. For instance, less than half considered the treatments they prescribed to be effective. They also found diagnosing these problems difficult. Interestingly, particularly, they found it difficult in women. So 2/3 of the GPs regarded diagnosing female sexual problems as being difficult, compared with less than half reporting the same for male sexual problems. It seems that the most commonly discussed issues were erectile dysfunction, decreased libido, and painful intercourse, or dyspareunia.
Yeah, it seems like this is a core part of general practice that may need more confidence and skills.
So before getting into the clinical details, shall we start with the consultation itself? How can a healthcare professional make it easier for patients to talk?
So we have a learning module on psychosexual disorders in women, and that says the first step is to create a safe, non-judgmental space. This is because we know that patients are often reluctant to talk about sexual dysfunction out of embarrassment or out of fear that their concerns will be dismissed.
Right, exactly, Dawn. But of course, it's not just patients, is it? The authors of this module, gynecologists Miss Leila Frodsham and Miss Eleanor Sine, say that studies show healthcare professionals also fear these discussions because of worries about embarrassing themselves, limited time, and lack of training.
And it's important to remember there may be subtle signs that a person is experiencing sexual dysfunction. A classic example given in the module is repeated non-attempts of cervical screening, and this could indicate that the person has sexual difficulty and that's why they're not attending the screening.
Yeah, using open-ended questions is key in these consultations, and it might feel like it will take longer than a structured pro forma, but the module authors say that in reality, this approach often leads to shorter and more satisfying consultations for both the patient and the practitioner. And to help guide the initial conversation, the acronym LOFTY can be used. That's listening, observing, feelings, thinking, and interpreting.
This module also outlines the PLICIT model, which offers a structured method for introducing sexual dysfunction into the conversation and then offering counselling and treatment. It has 4 levels of intervention. The first is P for permission, which is all about creating that safe space that allows patients to bring up their sexual concerns. The second is LI for limited information, where you might identify a potential cause if there is one. There is also SS for specific suggestions, which covers discussing differentials and specific management ideas. And finally, there's IT for intensive therapy, which means onward referral to services like gynecology or psychosexual medicine.
Yeah, and what's so powerful about this model is that it shows that for many people, an empathetic and listening practitioner who provides that initial permission can be enough. They may process the cause of their problem just by talking about it, and the module says that only a minority will actually need that onward referral for intensive therapy.
A physical examination can also be part of this process. The authors describe it as a unique enabling moment. It's not just diagnostic, it can be also psychotherapeutic, providing insight into a patient's feelings about their body. It's a moment when feelings of vulnerability may surface, so it's crucial to reflect on the patient's response. Though if the patient has experienced sexual trauma in the past, a physical examination could make them very nervous.
That's such an important point, Dawn, and patients often hope for a physical cause to be found according to this module. So if the examination is normal, communicating this requires great care. The authors say that simply telling the patient everything's normal can feel dismissive and shut down the conversation.
Yeah, and the module does give some great practical tips for conducting intimate examinations. Things like ensuring the room is warm, the door is locked, and a modesty sheet is provided. That does remind me, I went for an ECG a while ago, and I think I was quite worried when I was undressing so they could put the machine on. The window didn't seem to have a curtain, so, make sure if there is a window, make sure that that's covered.
That's covered as well, yeah.
And to add to all of that, offering a trained chaperone is also important. And trying to conduct the exam in the same room as a consultation helps because that can help reduce disruption.
Okay, so having considered some general points about the consultation, let's dive into specific presentations that you may see in primary care, starting with women. Painful intercourse or dyspareunia is a common one.
Yeah, so sexual pain disorders affect around 7.5% of women, and the module on psychosexual disorders explains that it's vital to distinguish between superficial and deep dyspareunia. Superficial dyspareunia is pain at the vaginal entrance that typically starts with the initial penetration. Deep dyspareunia is felt deeper in the vagina, lower abdomen or pelvis during or after penetration. The module stresses that deep dyspareunia is rarely psychosexual and should be initially referred to gynecology to exclude conditions like endometriosis or adnexal pathology.
Right, and given that we were just talking about gynecological examinations, it's probably worth mentioning vaginismus here. The DSM-5 defines vaginismus as part of the spectrum of genitopelvic pain disorders and penetration disorders, along with dyspareunia. But in contrast to what you just said about deep dyspareunia rarely being psychosexual, the module authors say that with vaginismus, it's helpful to consider it as a symptom that expresses psychological distress, which may or may not be physical in origin, and which may be caused by a combination of factors. But returning to dyspareunia, in his module on this topic, Dr. Pippin Singh, a GP, outlines a number of red flag symptoms that should prompt urgent investigation.
Yeah, and these include dysmenorrhea, intermenstrual or postcoital bleeding, pelvic pain or discharge, unintentional weight loss, and fever.
He also points out that dyspareunia may not be the presenting complaint, but might be revealed when screening someone for other gynecological symptoms.
Yeah, I mean, there's so many potential causes of painful intercourse, and the list in the module is really quite extensive. So I'm not going to go through them all, but it does include genitourinary symptoms of menopause, genital dermatoses, such as lichen sclerosis, postnatal issues like perineal scarring and vulvodynia. Then there can be structural abnormalities or even non-gynecological reasons like IBS or constipation. A drug history is also key, as a contraceptive pill, some antidepressants and antihypertensive can all reduce vaginal lubrication. Recurrent candida infection is worth considering, and candida is common when estrogen levels are high. And in somebody with recurrent candida, B alerts the possibility that diabetes is the cause. And we'll be coming back to sexual disorders and women diabetes later.
Yeah, you mentioned vulval pain or vulvodynia, Dawn. Can we talk a bit more about that?
In a clinical review, Mr. Abdelmajid Abdelrahman defines vulvodynia as a sensation of vulvar burning and soreness in the absence of any obvious skin condition or infection. It is estimated that around 16% of women have experienced this for at least 3 months at some point in their life. It's important to distinguish between the two main types: unprovoked pain, which can be generalised or localised and is often described as burning and soreness, and provoked pain, which is pain on light touch, which might include things like tampon use.
Right, and taking an effective history is crucial here. So Mr. Abdelrahman's review suggests asking about the nature of the pain. Is it burning, sharp or stinging? And any triggers like cycling or long periods of sitting. Psychosexual history is vital as well, so asking questions like, do you have any concerns about your sex life, and is sex painful? And as we said before, clinical examination is often normal because the problem is with the nerve fibres, but it's essential to exclude other vulval conditions that could cause similar symptoms, such as lichen sclerosis or erosive lichen planus.
And on that point, the authors of our psychosexual disorders module advise avoiding routine swab tests to investigate localised provoked vulvodynia, as it is painful and can imply disbelief of the person's pain.
Yes, and management of vulvodynia is complex, but practical advice is key. So vulval dermatitis may be a consideration, and you can advise patients to avoid soaps and shower gels and to wear cotton or bamboo underwear. Women often buy over-the-counter antifungal treatments, which can soothe symptoms initially, but then precipitate a hypersensitivity reaction that makes things worse. Let's move on to an increasingly common presentation, which is low libido. I spoke to Dr. Olivia Hum, a GP and menopause specialist and MIMS Learning's clinical advisor on women's health at MIMS Learning Live earlier this year. And she told me that lack of libido is not something that GPs ever really used to see in women in primary care. But she added that after 20 years of practice, she's started seeing women increasingly presenting with this in the last few years.
Yeah, so our module on psychosexual disorders refers to this as hypoactive sexual desire disorder. It's a multifactorial disorder with psychological, social and biological causes. I actually identify as asexual, which means I do not experience sexual attraction, and the concept of hypoactive sexual desire disorder is extremely controversial within the ACE community. And just to say, asexual and ace are interchangeable. So some see it as medicalising asexuality, similar to how homosexuality was classed as a mental health disorder in previous decades.
That is really interesting, Dawn.
Yeah, so I just can't stress this enough, that for a true diagnosis of hyperactive sexual desire disorder, the symptoms must cause clear distress and interpersonal difficulty. And I think the challenge would be determining whether the woman is distressed because she has a low libido or because she thinks she should be interested in sex, which are two very different things. Self-identification of a lifelong lack of sexual desire as asexuality precludes the diagnosis.
Absolutely. But for those who are diagnosed with hyperactive sexual desire disorder, this learning module advises psychosexual input, which might involve discussion about partner or relationship impact and any unrealistic or contrasting ideas on normal sexual function, exploring the origin of the problem, and a couples-based intervention called Sensate Focus. So linked to what you just said, Dawn, Dr. Hum made a crucial point at MIMS Learning Live about not over-medicalising low libido, particularly in women, where she says the cause of low libido often isn't a hormone deficiency, but rather things like tiredness, being in a long-term relationship and generally feeling overwhelmed.
And so in which case, presumably, things like testosterone supplementation is not going to help.
Exactly. So Dr. Hum says menopausal women may ask about testosterone supplementation, but testosterone is not going to be the answer for those issues that she highlighted. And she also notes that there's very little correlation between measured testosterone levels and libido symptoms. She recommends signposting women to the book Mind the Gap by psychosexual psychologist Karen Gurney, which is all about sex in long-term relationships and how female desire can differ from male desire. Women often come back feeling normalised after reading it, she says, realising that their experience is common.
Okay, so what about the role of testosterone for those women where it might be appropriate?
So Dr. Hum explained that for some postmenopausal women, if they are adequately estrogenised on HRT and all of their other symptoms are managed, but they still have absolutely no sexual thoughts or desire, a small increase in their testosterone level can make a real difference. And the British Menopause Society guidance says that if you've tried everything else, you can consider a 6-month trial, but it does involve using unlicensed preparations. So if you want to hear a bit more on this, then do listen to the bonus episode of the podcast that I recorded with Dr. Olivia Hum, and you can find that on our website, mimslearning.co.uk.
I said we'd be talking about this later, but now I think is the time. Should we now talk about sexual issues in women with diabetes?
Yeah, so we have an interesting learning module on sexual dysfunction in women with diabetes, which says that the prevalence is thought to be about double that of women without diabetes. And the issues can be directly linked to diabetes itself. For example, hyperglycemia can reduce blood flow, contributing to vaginal dryness and painful sex. Also, the risk of hypoglycemia during sex is common and may require planning that detracts from spontaneity. And despite this strong link, sexual well-being is not routinely discussed in diabetes clinics, partly due to the embarrassment factor that we mentioned earlier for both patients and clinicians.
Yeah, and for this reason, the author of the module, Dr. Kirsty Winkley, flags up that screening questionnaires may be useful. There are several validated questionnaires that can be used to screen for sexual dysfunction in women, but the most widely used is the Female Sexual Function Index. However, at the time that the module was written, there was no validated questionnaire specifically looking to screen for sexual dysfunction in women with diabetes.
And blood tests may be needed to determine whether thyroid function or the levels of circulating sex hormones are a factor in the dysfunction. If a cause unrelated to the diabetes is identified, onward referral may be necessary. Dr. Winkley adds, though, that during diabetes consultations, practical advice could be provided on how to manage blood glucose levels and how to avoid hypoglycemia during or after sex. For example, she also says that phosphodiesterase 5 PDE5 inhibitors such as sildenafil or tadalafil are not currently licensed for treating female sexual dysfunction, but there is some evidence to suggest that they could be used to improve enjoyment of sexual activity in women with type 1 diabetes.
Okay, so the drugs you've just mentioned are, of course, established treatments for erectile dysfunction, which does bring us rather neatly to the topic of male sexual problems.
Yes, and erectile dysfunction is a key topic in male sexual health. So what are the main takeaways for primary care, Dawn?
Okay, so Professor Mike Kirby said this at MIMS Learning Live South back in June. So he said that erectile dysfunction is a marker of coronary artery disease and it represents a crucial window of opportunity to intervene. He explained that men with erectile dysfunction, or ED, have endothelial dysfunction, and the risk factors for coronary artery disease are exactly the same as they are for ED. He and his colleagues in a research paper found that ED occurs on average 3 years before the first cardiac symptom and 5 years before myocardial infarction.
Those are stark statistics, and this was backed up as well in Dr. Pippin Singh's Red Flags module on ED, where he advises using the Q-Risk3 tool, if it's available, to assess the patient's risk of cardiovascular disease. He says the history should be comprehensive, asking about the timeline of ED development and whether the patient has morning erections. If they don't, a hormonal cause is more likely to be the primary issue.
And just to say, of course, if the Q-Risk3 tool isn't available, then there's the Q-Risk2. Okay, but what about other examinations and investigations?
So Dr. Singh's module says assessment should include blood pressure, BMI and pulses in all limbs. A urine dipstick should also be done. Relevant blood tests include a full lipid profile, HbA1c, and liver, renal and thyroid function tests. Testosterone levels can be checked, but it must be an early morning sample. Importantly, a PSA test should only be checked in an appropriate person who's been fully counselled about this test and its implications.
And speaking of counselling patients, Professor Kirby busted a common myth in his MIMS Learning Live South presentation, which is the idea that sex is dangerous for men with heart disease.
He did. He explained that sex is just another form of exercise, and having vigorous sex only uses about 5 to 6 metabolic equivalents, which is comparable to a round of golf or walking a mile in 20 minutes. He said that if a man with coronary artery disease can exercise without experiencing ischemia, he should be able to have sex without ischemia. He also made the point that PDE5 inhibitors like sildenafil are advantageous because they actually improve endothelial function and reduce the risk of future cardiovascular events, whereas nitrates are only a symptomatic treatment.
What about premature ejaculation? That's another common but underreported issue in men.
Yeah, a clinical review on this topic by Dr. Abubakar Jha confirms it may be the most common male sexual disorder, but following the general theme, as she said, most men don't seek medical advice. The International Society for Sexual Medicine has a clear definition of premature ejaculation, and that is that it involves ejaculation that always, or nearly always, occurs before or within about 1 minute of penetration for lifelong PE, or a clinically significant reduction in time, often to about 3 minutes or less, for acquired PE. Crucially, it also includes an inability to delay ejaculation and negative personal consequences such as distress, frustration, or avoidance of sexual intimacy.
So the diagnosis isn't just about timing, it's about the distress it causes.
Which is similar to what we were saying earlier about low libido. And in premature ejaculation, the etiology is now thought to be multifactorial, including psychological, environmental, and neurobiological factors.
Yes, and to that end, management can involve behavioural therapy, particularly for acquired PE, and psychotherapy to help relieve anxiety and build confidence. Pharmacological therapy is also an option. The most established form is local anaesthetics like lidocaine and prelocaine cream or spray, used 20 to 30 minutes before intercourse. Off-label use of SSRIs is also common, as they can delay ejaculation by increasing synaptic serotonin levels.
Thank you, Dawn. This has been a really practical discussion covering a huge amount of ground. So, what have we learned today? First, sexual problems are common, affecting a large percentage of the UK population, yet they remain underreported and undertreated. Creating a safe, non-judgmental space is crucial, and for many patients, just having permission to talk can be therapeutic in itself. Second, when managing female sexual pain, a detailed history is key to differentiating between conditions like superficial dyspareunia, deep dyspareunia, which warrants gynecological referral, and vulvodynia. The intimate examination itself can be a therapeutic tool if handled with sensitivity, empowering the patient by handing over control to them. Third, GPs shouldn't automatically medicalise low libido, particularly in women, in long-term relationships or in midlife. Factors like tiredness, stress, and feeling overwhelmed are common culprits, and signposting to resources that normalise these experiences can be very effective as a first-line intervention before considering hormonal treatments. And let's not forget Dawn's interesting emphasis from the perspective of the ACE community that there is no cause for any diagnosis unless there is clear distress and interpersonal difficulty. And finally, for men presenting with erectile dysfunction, it must be considered a significant red flag for underlying cardiovascular disease. The presentation is a vital window of opportunity to perform a full cardiovascular risk assessment and to intervene with lifestyle advice and treatment to prevent major cardiac events down the line. Don't forget that you can claim CPD credits for listening to these podcasts, and there are many more available. To get your certificate, along with links to the resources mentioned, just go to our website at mimslearning.co.uk. You've been listening to the MIMS Learning Clinical Update podcast, produced by Jude Owen. We hope you'll join us again next week when our colleague Sangeeta will be talking to Dr. Joy Shacklock, the RCGP Safeguarding Lead, about child safeguarding. See you then.